Welcome back to the deep dive. Today, we are stripping away, the vanity metrics of the human body.
Hmm.
We spend a massive amount of time talking about the heart, the pump or the brain, the computer. We obsess over heart rates and cognitive function.
Right, the glamour organs.
Exactly. But today we are going down to the engine room. We are talking about the master chemists. The ultimate water treatment plant that keeps you from literally poisoning yourself from the inside out. The kidneys.
It is a fascinating system to dig into, and I love that description, master chemists.
It feels right, doesn't it?
It's exactly what they are. I mean, the level of precision with which the kidneys balance our internal environment down to the molecule is it's staggering. When they're working, you don't even know they exist. They are silent workers,
Completely silent.
but when they fail, it's catastrophic.
Yeah.
The body becomes a toxic environment in a matter of hours.
And the stakes here are incredibly high. I was looking through the source material for today, which is drawn from a pretty intense nursing unit on advanced renal concepts and critical care management. And one statistic just stopped me in my tracks. I think we need to start there just to frame the importance of this organ.
You're talking about the donor statistics.
Exactly. It said that one single organ donor can save up to 8 lives. 8.
Yeah.
And a single tissue donor can improve the lives of over 75 people.
It's profound, isn't it? It really highlights the scarcity and the value of these biological machines we have.
It's massive, and I think that frames our mission for this deep dive perfectly. We aren't just memorizing biology or physiology, we are exploring the spectrum of survival. We're going to look at what happens when the system crashes, specifically acute kidney injury. We're going to break down the life support systems we've invented, like dialysis. And finally, we're going to look at the ultimate reset button, transplantation.
And importantly, as you mentioned, we're viewing this through the lens of the nurse.
Yeah.
Because in the hospital, when a patient's kidneys are shutting down, it isn't the surgeon or the nephrologist standing at the bedside hour by hour.
No.
It's the nurse. They are the ones monitoring the trends, catching the subtle signs of decline, and essentially keeping that patient alive until function returns or a new organ is found.
So let's get into the crash. The source material focuses heavily on this concept of AKI, acute kidney injury. I feel like in the past, people just called this kidney failure. Is there a difference, or is this just, medical rebranding?
There is a huge difference, and the distinction is vital for how we treat it. The key word in AKI is acute.
Right.
This is a rapid, abrupt decline in kidney function. We're talking about something happening over hours or days, not years.
Versus chronic kidney disease, which is the slow burn.
Right. CKD is the diabetic patient whose kidneys slowly degrade over 20 years due to high sugar or high blood pressure. That damage is usually permanent. It's scar tissue.
Oh.
AKI is different because, theoretically, it is reversible.
Oh.
If we catch the cause and fix it fast enough, the kidneys can bounce back. They are resilient if you give them a chance.
But to catch it, we need to see it coming. What's the red flag? What is the clinical definition here?
Clinically, we look for 3 specific markers. First, a rapid rise in serum creatinine. Second, and often appearing earlier, a reduction in urine output. And third, the development of something called azotemia.
Azotemia. That sounds like a villain in a Marvel movie. I am azotemia, destroyer of worlds.
It does, doesn't it? But it's essentially the accumulation of nitrogenous waste products in the blood.
Okay.
We're talking about urea nitrogen, which we measure as BUN, and creatinine. Normally, the kidneys filter these out constantly. They are metabolic trash. When the filter stops, that trash stacks up in the blood very, very quickly.
So the filter is clogged or stopped. To fix it, we have to know why. The text uses this framework of 3 categories to diagnose the cause: pre-renal, intrarenal, and postrenal. I found the analogies here really helpful to visualize what's going wrong.
This is the standard diagnostic framework. You have to locate the injury relative to the kidney. Is it before, inside, or after?
Let's start with category 1, pre-renal. Pre meaning before.
Correct. Think of the kidney as a house. Pre-renal failure means the plumbing leading to the house is broken.
Okay.
The house itself, the kidney, is structurally fine. The machinery works, the lights turn on. But it's a supply chain issue. It's not getting any water, or in this case, blood to process.
So no flow, no filtration.
Exactly. The fancy term is perfusion. If you don't have perfusion blood flow, you can't have glomerular filtration. The kidney basically goes into hibernation mode to save itself. It clamps down.
What breaks the supply chain? What causes this loss of flow?
Anything that drops the blood volume or the blood pressure significantly. Hypovolemia is a classic cause severe dehydration, hemorrhage, where you've lost a lot of blood, or severe burns where you lose fluids through the skin.
What about the pump itself? If the heart's not working?
Absolutely.
Yeah.
Decreased cardiac output. If you have a massive heart attack or you're in severe heart failure, the pump isn't strong enough to push blood all the way to the kidneys. The kidneys are at the end of the line, in a way. If the pressure's low, they starve.
I saw sepsis on that list, too. That seems different than just low volume.
Sepsis is a distribution problem. It causes massive vasodilation. The blood vessels widen all over the body, pressure drops, and blood pools in the periphery, in your arms and legs, into the getting to the vital organs. It's like turning a fire hose into a garden sprinkler. The pressure just disappears.
So if I'm a nurse at the bedside, how am I spotting a pre-renal issue? I assume I'm looking for signs that the patient is dry or in shock.
Precisely. You're looking for volume depletion. You check the skin turgor. Does the skin tent up when you pinch it?
Right.
Are the mucous membranes in the mouth dry and tacky? Is the heart rate up?
Why does the heart rate go up?
It's compensation. Tachycardia. The body senses the low pressure, so the heart beats faster to try to maintain flow.
Right, it's trying to make up for it.
Yeah. You'll also see hypotension, low blood pressure.
Speaking of blood pressure, there was a very specific number mentioned in the text that nurses watch like a hawk, the MAP.
The mean arterial pressure. This is the holy grail number in renal nursing and critical care.
Really?
Oh, yeah. The kidneys are very sensitive organs. They are absolute divas about pressure. They generally need MAP of at least 65 millimilli Hg to maintain perfusion.
So if the monitor says the MAP is 60...
If it's 60, the kidneys are starving. They effectively shut the doors. So the nurse needs to intervene immediately.
What's the intervention?
Usually that means fluids, giving them a bolus of saline to fill the tank, or using vasopressors to tighten the vessels and get that MAP above 65.
There was also a lab clue for pre-renal that I thought was fascinating, the BUN to creatinine ratio.
This is a cool piece of physiology.
Yeah.
It helps distinguish pre-renal from the other types.
Oh, so?
In pre-renal failure, the flow of blood through the kidney is slow and sluggish. Because it's moving so slowly, the kidney has time to reabsorb a lot of urea back into the blood, but it doesn't reabsorb creatinine. Creatinine is always waste.
So the BUN goes up, but the creatinine stays relatively stable.
Exactly. We look for a ratio greater than 20.1. If you see the BUN skyrocketing, say it's 80, while the creatinine is only creeping up, say it's 2.0, it's a high ratio.
And that tells you something very specific.
It screams pre-renal. It tells the nurse, if this patient is dry, give them fluids.
Okay, moving to category 2, intrarenal.
Intrarenal means the injury is inside the kidney itself.
The house is on fire.
The house is burning. This is direct damage to the parenchyma, the kidney tissue, and specifically the nephrons, which are the functional units that actually do the filtering.
What starts the fire?
Well, it can be a continuation of pre-renal issues. If you leave the kidney without blood flow for too long, the tissue starts to die from ischemia.
Okay, lack of oxygen.
Right. Lack of oxygen causes cell death. But the other major culprit, and this is a huge focus in nursing safety, is nephrotoxins.
Poisons.
Chemical damage. And often, sadly, these are medications we give to treat other things. We cause the damage.
What are the big offenders?
Antibiotics are a big class. Specifically, aminoglycosides like gentamicin. If you don't monitor the levels in the blood, they destroy kidney tissue. Another one is contrast dye, the stuff used for CT scans and angiograms.
That's why they always ask if your kidneys are okay before a CT scan.
Exactly. Contrast-induced nephropathy is real. Other offenders include NSAIDs, ibuprofen, naproxen, if taken in massive chronic doses.
So Advil, Aleve.
Yeah. These things chemically burn the epithelial cells inside the kidney tubules.
The text mentions a specific condition here called acute tubular necrosis, or ATN. It says it's the most common intrarenal cause. What is actually happening in the plumbing there?
Imagine the tubules inside the kidney are lined with tiles. Those are the epithelial cells. In ATN, due to toxins or lack of oxygen, those tiles die.
Okay.
They detach from the wall and slew off into the pipe.
So now you have debris clogging the system from the inside.
Precisely. The dead cells plug the tubules, urine can't pass, pressure builds up inside the nephron, and filtration stops. It's a mess. When nurses look at a urinalysis, they might see casts, which are basically clumps of these dead cells.
There was another intrarenal condition that stood out because the symptom description was so vivid. Rhabdomyolysis.
Rhabdo. This is a classic emergency, and nurses need to spot it instantly. It happens when there is massive skeletal muscle breakdown.
How does that happen?
Trauma is a big one, a crush injury from car accident. But we also see it in the elderly who fall at home, can't get up, and lie on the floor for 2 days.
Oh, wow.
The pressure on the muscles causes the cells to burst, or even extreme exercise in someone not conditioned for it.
And when muscle cells burst, they release.
Myoglobin.
And kidneys hate myoglobin.
They can't handle it. Myoglobin is a large, heavy protein. It's like trying to flush a bowling ball down a toilet.
That's a great visual.
It gets stuck in the tubules and blocks them completely. It's physically obstructing the microscopic filter.
And the sign, the text said cola-colored urine.
Dark, brown, tea, or cola-colored. It's unmistakable. If a nurse sees that in a catheter bag, the alarm bells should ring. Immediately. They know the patient's muscles are breaking down, and they need to intervene right now.
What is the intervention?
Fluids. Massive amounts of fluids. You have to flush the system. You try to force those bowling balls through before they solidify and destroy the kidney permanently.
Okay, prerenal, plumbing supply. Intrarenal, house fire. Finally, category 3, postrenal.
Postrenal is after the kidney. The sewer line is clogged.
So the kidney's making urine, the house is fine, the supply is fine, but it has nowhere to go.
Correct. It's an obstruction of urine outflow. This causes retrograde pressure. Yeah, backflow. The urine backs up into the ureters, then into the renal pelvis. It causes the kidney to swell. That's called hydronephrosis. That back pressure eventually equalizes with the filtration pressure, and everything stops.
What are the usual suspects for a clogged sewer line?
In older men, the number one cause is BPH, benign prostatic hyperplasia.
The enlarged prostate.
Exactly. The prostate wraps around the urethra. When it enlarges, it squeezes the urethra shut like a clamp.
Kidney stones.
Definitely. Calculi. If a stone gets stuck in the ureter, it blocks the flow. Tumors can do it too. Or functional issues like a neurogenic bladder in spinal cord injury patients or MS patients, where the bladder just doesn't receive the signal to squeeze and empty.
And the nursing assessment here relies on a specific piece of tech, the bladder scanner.
The nurse's best friend in these cases. It's a bedside ultrasound. Imagine you have a patient who hasn't urinated in 6 hours. Their kidneys might be failing, intrarenal, or they might just be full and blocked, postrenal. How do you know?
You scan them?
You scan the bladder. If the scanner shows 0 millimol, the kidneys aren't making urine. That's prerenal or intrarenal.
Okay.
But if the scanner shows 800 millimoles of urine sitting in the bladder, that's postrenal. That's retention.
And the solution is usually mechanical.
Right. You catheterize them. You bypass the obstruction.
What if they already have a catheter and the urine stops?
Check the tubing. It sounds so simple, but kinks in the tubing or a clot blocking the catheter are common causes of kidney failure that are fixed in 2 seconds by straightening a tube.
Oh.
The nurse has to be a detective. Start with the simplest mechanical explanation first.
So we have the categories, but the text also mentions a scoring system called RIFLE. RIFLE. Why do we need an acronym?
In medicine, we love standardized criteria. RIFLE helps us stage the severity of the kidney injury. It stands for risk, injury, failure, loss, and end stage.
So it's a way for everyone to be on the same page.
Exactly. It helps the whole team speak the same language about how bad the situation is.
And what are we measuring to stage them?
2 things, creatinine and urine output.
Why both?
Because sometimes creatinine lags behind. It can take 24 to 48 hours for creatinine to rise after an injury, but urine output, that drops immediately.
So urine output is the early warning system.
Exactly. If a patient's urine output drops below 0.5 mL/kDH/R for 6 hours, that's the risk stage. The nurse spotting that trend can save the kidney before the creatinine ever spikes.
Okay, so we've diagnosed the crash, we know where it came from, but now the body is dealing with the consequences. The source material describes the body in toxic shock or uremia. It seems like when the kidneys quit, everything breaks.
It's systemic. The kidneys regulate so much fluid balance, electrolytes, acid base, blood pressure, red blood cell production that when they stop, every organ system takes a hit.
Let's talk about the lungs first. I remember reading about a specific breathing pattern, Kussmaul respirations. Why do the lungs care if the kidneys are failing?
Because of acid. This is cool physiology.
Yeah.
The kidneys are the primary way we excrete hydrogen ions acid from the body. When they fail, that acid builds up. The body enters metabolic acidosis. The pH drops.
And the body hates being acidic.
It can't function. So the lungs try to fix this. Carbon dioxide, CO2, is also acidic. If you breathe it out, you lower the acid load. So the brain tells the lungs, hyperventilate, blow off the CO2.
So the patient starts panting.
Deep, rapid, gasping breaths. Those are Kussmaul respirations. It isn't a lung problem. It's a kidney problem that the lungs are trying to solve.
Wow.
It's a compensatory mechanism.
That is fascinating. What about the neurosystem?
The toxins affect the brain. We call it uremic encephalopathy.
Yeah.
The urea and waste products cross the blood-brain barrier. The patient gets fatigued, confused, lethargic.
So from a nursing perspective, safety is the priority.
Absolutely. They are a fall risk. They might be confused. And because of electrolyte imbalances, they are a seizure risk.
Oh.
So the nurse initiates seizure precautions and does frequent neurological checks using the Glasgow Coma Scale, GCS, to catch any decline in mental status.
What about the skin? There was a term, uremic frost.
This is rare now because we usually start dialysis before it gets this bad, but historically, in severe cases, the urea levels in the blood get so high that the body tries to excrete urea through the sweat glands.
You're sweating out urine, basically.
In a way, yeah.
Mm-hmm.
When the water in the sweat evaporates, it leaves a crystallized powdery frost of urea on the skin. It looks like white dust.
And I assume that itches.
Intensely. Severe pruritus. Patients will scratch their skin raw. So nursing care involves keeping the skin hydrated, cutting fingernails, and trying to prevent infection from open scratches.
Now, probably the most dangerous part of the fallout seems to be the fluid and electrolyte chaos. The text says, strict INO.
Strict means strict. I can't emphasize this enough. In a healthy person, you drink a liter of water, you pee a liter. The kidneys balance it.
Simple enough.
In a renal patient, that liter stays in the blood.
And where does it go if you can't pee it out?
It leaks into the tissues edema. It goes to the lungs, pulmonary edema, causing crackles and shortness of breath.
Right.
It stresses the heart, causing distended neck veins, JVD, and high blood pressure.
So nurses are tracking every drop in and out, but there's another metric mentioned, daily weights.
Daily weights are the gold standard for fluid monitoring.
Why is weight better than just measuring urine?
Because it captures insensible loss and it's objective. Here is the math. 1 kilogram of weight gain is roughly equal to 1 liter of retained fluid.
That's a great rule of thumb.
It's crucial. If a patient gains 2 kilograms overnight, they didn't gain 2 kilograms of fat or muscle. They retained 2 liters of fluid.
Wow.
That tells the nurse exactly how much fluid needs to be removed via dialysis or diuretics. It is actionable data.
And then there's the electrolytes, specifically potassium, the silent killer.
Hyperkalemia. The kidneys are the main exit strategy for potassium. When they stop, potassium levels rise. And the heart is very, very sensitive to potassium.
Why is it so dangerous?
It affects the electrical conduction system of the heart. High potassium causes dysrhythmias. It can lead to cardiac arrest very quickly. It's a top priority emergency.
The source outlines a cocktail for treating this. I want to walk through the logic because it seems like a chemistry experiment. We have calcium gluconate, insulin, and polystyrene. They seem unrelated. How do these work together?
It's a 3-step strategy. Defend, hide, and remove.
Okay, step 1, defend.
That's the calcium gluconate. This is important. Calcium gluconate does not lower the potassium.
It doesn't.
No. It stabilizes the cardiac cell membrane. It raises the threshold for excitation. Basically, it puts a shield around the heart so the high potassium doesn't stop it.
So it just buys you time.
It buys you time, exactly.
Okay, calcium is the shield. Step 2, hide.
We give IV regular insulin and glucose, dextrose. Insulin has a side effect. It opens the cell doors and pushes potassium out of the blood and into the cells.
And the glucose is just there to stop the insulin from crashing their blood sugar.
Exactly. You don't want to trade hyperkalemia for hypoglycemia. So you get sugar with the insulin. It's a temporary fix. You're hiding the potassium in the cellular closet.
Right.
It's still in the body, just not in the blood where it hurts the heart.
Step 3, remove.
We need to actually get it out of the body. That's where sodium polystyrene, commonly known as Kayexlate, comes in. You drink it or give it as an enema. It binds to the potassium in the gut and excretes it through the stool.
It causes diarrhea.
Usually, yes.
Yeah.
But that diarrhea is carrying the potassium out of the building.
Shield, hide, exit. That makes sense.
It's a standard protocol, and every ICU nurse knows it by heart.
Before we move to dialysis, let's touch on nutrition briefly. This seemed like a paradox to me. The patient is in a hypercatabolic state, breaking down muscle, but we have to restrict protein.
It is a delicate balance.
Yeah.
The body is stressed and breaking down its own muscle, which releases more nitrogen waste.
Okay.
But if we feed them high protein, we add more nitrogen waste urea that the kidneys can't clear.
So what do they eat?
We restrict protein to prevent azotemia, but we have to give them enough calories in healthy fats and carbohydrates to stop the muscle breakdown. It's a tightrope walk.
So we've managed the crash, we're balancing the fluids, we're shielding the heart, but let's say the kidneys aren't bouncing back yet. We need a substitute. We need dialysis.
The life raft.
The concept is simple enough, moving fluid and molecules across a semi-permeable membrane. But there are two main types: peritoneal dialysis, PD, and hemodialysis, HD. Let's start with PD. This one happens inside the body.
Yes. In peritoneal dialysis, we use the patient's own peritoneum, the serous membrane lining of the abdominal cavity, as the filter.
How does that work?
You surgically place a silicone catheter into the belly. You fill the abdominal cavity with a special fluid called dialysate. You let it sit there. That's called the dwell time.
And while it sits.
Physics takes over. Osmosis and diffusion. The lining of the belly is extremely vascular, lots of blood supply. The waste products in the blood move across that lining into the dialysate fluid because of the concentration gradient.
And how do you get the water out?
The dialysate fluid usually has a high concentration of glucose sugar. That sugar acts like an osmotic magnet. It pulls excess water out of the blood and into the belly.
Then you drain it.
Right. After the dwell time, you unclamp the tube, drain the fluid into a bag on the floor, and the waste and water go with it.
What's the advantage of this? It sounds cumbersome.
The beauty of PD is that patients can do it at home. It gives them independence. They don't have to go to a clinic 3 times a week. There's CAPD, continuous ambulatory peritoneal dialysis, which is manual. The patient does exchanges throughout the day. And there's APD, automated, where a machine does the exchanges at night while they sleep.
But there's a catch: the infection risk.
Peritonitis. It's the enemy of PD. You have a tube going directly into a sterile body cavity. If bacteria get in, it's serious.
What does the nurse teach the patient to look for? The text mentioned cloudy effluent.
Every time they drain that bag, they have to look at it. It should look like clear, straw-colored urine.
Okay.
If it looks cloudy or milky, that indicates the presence of white blood cells and bacteria. That is peritonitis.
Any other signs?
Abdominal pain. Rebound tenderness, where it hurts more when you let go than when you press. A rigid, board-like abdomen.
So the teaching focus is really on
aseptic technique. Meticulous surgical-level cleanliness when connecting and disconnecting those bags. Masks, hand hygiene, turning off fans, no pets in the room. It has to be perfect every time.
Now let's talk about the one most people picture: hemodialysis, HD. The machine. The artificial kidney.
This is the more aggressive route. We pull the blood out of the body, run it through a dialyzer, which is a filter cartridge in the machine, clean it, and pump it back in.
To do this, you need a serious connection. A standard IV won't work, will it?
Not a chance. A standard IV can't handle the flow rate. We need to move 300 to 500 millimoles of blood per minute. An IV would collapse.
Wow.
So surgeons create an AV fistula or a graft.
How does that work?
For a fistula, they surgically sew an artery and a vein together, usually in the forearm.
That sounds intense. Connecting a high-pressure artery to a low-pressure vein?
It causes the vein to bulge and thicken. It arterializes. It becomes tough enough to handle large needles being inserted repeatedly.
And there is a classic nursing assessment for the fistula. Feel the thrill, hear the brute.
It's a mantra. You put your fingers gently over the fistula. You should feel a buzzing vibration, like a purring cat or a cell phone vibrating. That's the thrill. It means blood is rushing through at high speed.
And the brute.
That's what you hear. You put your stethoscope on it. You should hear a turbulent rushing sound. Whoosh, whoosh. That's the brute.
If you don't feel the thrill or hear the brute,
silence is bad. It means the access has likely clotted off. That is a medical emergency, because that patient now has no lifeline for dialysis.
And there's a big safety rule about that arm, right?
Never do a blood pressure IV start or blood draw in the arm with the fistula.
Never.
You could damage it or cut off the flow. Nurses will often put a pink limb alert band on that arm to warn everyone.
Hemodialysis seems intense for the body. What are the complications during the actual treatment?
Hypotension is the most common. You're pulling fluid out of their blood volume rapidly. Their pressure can tank. You might see muscle cramps too.
And there's a condition called disequilibrium syndrome. That sounds disorienting.
It is. It happens usually in new patients or those with very high BUN levels. If you remove waste solutes from the blood too fast, the blood becomes cleaner than the brain tissue.
So there's an imbalance.
Right. By osmosis, fluid rushes from the blood into the brain cells to balance out the concentration.
So the brain swells.
Cerebral edema. Nausea, vomiting, headache, confusion. If that happens, the nurse has to slow down or stop the dialysis immediately.
Dialysis keeps people alive, but it's a grind. It disrupts life. The ultimate goal for many is a transplant.
The gift of life. It's the only potential cure.
Let's talk about the source of these organs. We have living donors and deceased donors. Living seems straightforward. You can give a kidney because you have two.
Right. You can live a perfectly normal life with one kidney.
Mm-hmm.
You can also donate a lobe of your liver, it regenerates, or even a lobe of a lung.
I didn't know that about the liver.
It's amazing. The benefit of living donation is that the organ usually functions immediately, and the matching can be done carefully in advance.
But the majority of organs come from deceased donors. And the text distinguishes between two types of death here: cardiac death and brain death. This is a heavy topic, but we need to understand the difference because it dictates what organs can be used.
It is heavy, but clinically crucial. Donation after cardiac death is when the heart stops. Circulation ceases.
The traditional definition of death.
Right. In these cases, once the heart stops, the organs are no longer getting oxygen. They start to die.
Yeah.
So we can usually only recover tissues, corneas, heart valves, bone, skin, and sometimes kidneys or liver if the team is extremely fast.
But not the heart itself.
No, the heart and lungs are usually lost.
And brain death.
Donation after brain death allows for the transplant of the heart and lungs. Why? Because the body is being artificially maintained on a ventilator. The heart is still beating. The blood is still oxygenated.
Yeah.
The organs are being perfused right up until the moment of retrieval.
But the person is legally dead.
Yes. The source material is very clear. Brain death is legal death. It is the irreversible cessation of all brain function, including the brainstem.
How does a clinician determine this? It seems like a massive responsibility. You can't get this wrong.
It is the ultimate responsibility.
Sure.
First, you have to rule out reversible causes. Is the patient hypothermic? Are they on drugs or sedatives? You have to clear all that.
And then the exam.
Then you test the brainstem reflexes. These are primitive reflexes that keep us alive.
Huh.
You shine a light in the eyes. Do the pupils constrict? If you touch the cornea with a cotton swab, do they blink? If you stimulate the throat, do they gag?
And in brain death?
Nothing happens. The lights are off. The brainstem is gone.
And the apnea test. That sounded intense in the reader.
It is the final physiological proof. You take the patient off the ventilator while still giving them oxygen down the tube, and you wait. You watch the chest.
What are you waiting for?
You are letting the CO2 build up in their blood. Normally, as CO2 rises, your brainstem screams, breathe. It forces you to take a breath.
It's an automatic reflex.
Totally. But in brain death, the CO2 rises to critical levels, and the patient makes no effort to take a breath. There is no drive. That confirms the respiratory center is destroyed.
Once that is declared, the nurse has a very specific role regarding the family. Or rather, a role they don't have. The text calls it a separation of roles.
This is an ethical firewall. The nurse caring for the patient is the advocate for that patient and their family. Their focus is saving that life, or if that fails, providing a dignified death. They should not be the one approaching the family to ask for organs.
Because it looks like a conflict of interest. Are you letting him die so you can take his kidneys?
Exactly. We never want a family to think that. So the nurse identifies the potential donor based on criteria, but they call the transplant coordinator. The coordinator is the expert, the firewall. They are the ones who have the donation conversation, separate from the care team.
It preserves trust. Okay, let's jump to the other side. The recipient. They've gotten the call, they've had the surgery, now they have a new kidney. The goal is to prevent the body from rejecting it.
The immune system is designed to kill invaders. It knows self from non-self.
Yeah.
It sees this new kidney as a dangerous foreigner.
There are 3 types of rejection mentioned: hyperacute, acute, and chronic.
Hyperacute happens minutes to hours after the transplant. This is rare now because of better cross-matching, but it means the recipient had pre-existing antibodies against the donor.
So the body was already primed to attack.
Yes. It's like an immediate massive attack. The organ essentially dies on the table. It turns white. It must be removed.
That's devastating.
It is. Acute rejection is more common. It happens days to months later. The body's T cells wake up and attack. The good news is this is usually reversible.
Okay.
We hit them with higher doses of immunosuppressants to quiet the immune system and save the kidney.
And
Chronic is a slow burn. Over months or years, scarring and fibrosis happen. It's irreversible. It's why transplants don't last forever. A kidney might last 10, 15, maybe 20 years.
To stop this or delay it, the patient is on a triple therapy of drugs.
It's a lifelong cocktail. Usually a calcineurin inhibitor like tacrolimus or cyclosporine, a corticosteroid like prednisone, and a cell cycle inhibitor like mycophenolate, Cellcept.
So they're hitting it from all sides.
They attack the immune response from 3 different angles.
And there's a specific dietary note here for those calcineurin inhibitors.
No grapefruit juice.
I always find that random, but why?
Grapefruit juice contains compounds that interfere with the CYP450 enzymes in the liver. These are the enzymes that metabolize the drugs.
Uh-huh.
If you drink grapefruit juice, the drug isn't broken down. It builds up to toxic levels in the blood, which can actually damage the new kidney.
So no grapefruit. Got it. But the trade-off for all this immunosuppression is obvious.
Infection. We are purposefully dampening the immune system. We are taking down the castle walls to let the kidney stay. But that means other invaders can get in.
So a common cold.
A common cold, a fungus, a UTI, things that are minor for you and me, can be lethal for a transplant recipient.
So the nursing teaching is all about protection.
Extreme vigilance, hand hygiene, avoiding crowds in the early months, washing vegetables thoroughly, cooking meat well done.
And there was a note about fever.
Yes, this is critical patient teaching. Because their immune system is suppressed, they might not mount a high fever.
Oh.
A slight temperature rise, maybe just 37.8 or 38 degrees Celsius, might be the only sign of a massive sepsis. They can't ignore feeling a little off.
So vigilance is the name of the game. It's a fragile victory.
It is, but it's a victory. It's life where there was none. It's freedom from the dialysis machine.
We've covered a massive amount of ground today. From the supply chain failures of prerenal AKI to the house fire of ATN. The strict monitoring of fluids. Remember, 1 kilogram equals 1 liter.
The shielding of the heart with calcium gluconate.
The cloudy bags of PD and the buzzing fistulas of HD. And finally, the profound ethics of brain death and the lifelong journey of transplantation.
It really highlights how complex renal care is. It isn't just one thing. It's chemistry, physics, ethics, and compassionate care all wrapped into one specialty.
And the nurse is the one tying it all together. They're the ones scanning the bladder, checking the fistula, listening for the bruit, and holding the hand of the family during the donation conversation.
Absolutely. The nurse is the sensory system for the medical team. Without those assessments, without catching that low urine output or that drop in MAP, the interventions fail.
Before we go, I want to leave the listeners with a thought from the very end of the source material. It mentioned xenotransplantation.
Using animal organs.
Specifically pigs. Because of the shortage of human organs, science is looking at genetically modifying pig organs to be compatible with humans. It sounds like science fiction, but it's becoming science fact.
It raises incredible questions. If we can create an unlimited supply of organs, does dialysis become obsolete? What are the ethical implications of raising animals for spare parts? It's a brave new world, and we are just stepping into it.
Something to mull over. And hey, check your own organ donor status. It takes 2 minutes and could save 8 lives. Thanks for diving deep with us.
Take care.